Welcome everyone to today's webinar titled The Effect of Depression and PTSD on Mother-Infant Sleep. My name is Tammy Astrop. I'm the coordinator for the Perinatal and Infant Health Program here at the Prevention Institute here in Saskatchewan. And before we go into today's session, I would like to acknowledge where I'm speaking from. I'm speaking to you from Treaty 6 territory, the traditional territory of Cree people and the homeland of the Métis Nation. I would like to pay respect to the First Nation and Métis ancestor of this place, and we affirm the importance of connection and relationships. We are committed to building relationships with the Aboriginal peoples and extending the reach of our efforts as an organization in both policy and practice. So just a bit about the institute where I work. It's a provincial nonprofit organization with a mission to reduce the occurrence of disabling conditions in children by providing evidence-based resources and information to providers, to families and communities. And our overall goal is healthy children. We do this through primary prevention methods by training, development of resources, and providing information, for example, like this webinar, according to current best evidence. We believe that children, regardless of their ability, have the right to the best physical, social, and emotional health possible. So we work in a variety of topic areas. One of them is perinatal and infant health, where I coordinate, and sexual reproductive health, FASD prevention, early childhood mental health, child injury prevention, child traffic safety, as well as parenting. So for the perinatal and infant health program, our mission is to increase awareness on emerging and re-emerging health issues relating to preconception health, pregnancy, and postnatal health. So we cover topic areas such as maternal mental health, like we'll be talking about here today, risk factors in pregnancy, such as weight gain during pregnancy, gestational diabetes, the impacts of environmental toxic exposures on maternal and fetal health, etc. So we normally provide information on those topics to health and allied health providers to better support their clients, and so that parents and families can better make informed decisions to support a healthy pregnancy. So before we go into this session, remember to use the Q&A box for your questions and answers, or even the chat box. I'll also quickly introduce our speaker for today. Our speaker today is Dr. Kathleen Kendall Tackett. She's a health psychologist and international board certified lactation consultant. She's the owner and editor-in-chief of Preclarus Press, a small press specializing in women's health. She's also the editor-in-chief of the journal Psychological Trauma and was the founding editor-in-chief of Clinical Lactation. She's also a fellow of the American Psychological Association, past president of the APA Division of Trauma Psychology, a member of the APA's Publications and Communications Board. Dr. Kendall Tackett specializes in women's health research, including breastfeeding, depression, trauma, and health psychology, and has won many awards for her work, including the 2019 President's Award for Outstanding Contributions to the field of trauma psychology from the American Psychological Association. She has authored more than 470 articles and chapters and is the author or editor of 39 books. So make welcome with me today, Dr. Kendall Tackett, as she takes us in today's webinar. Thank you.
Thank you very much, Jimmy, and thank you for all of you for tuning in today. I'm hoping that this will be helpful to you. Some of this may seem kind of familiar to you because, it's been included in a lot of other presentations, but I think actually I've got some new stuff here. And what I was really trying to kind of look at was, kind of this issue of, did what happened during pregnancy impact infant sleep? And kind of like, then how did that fall back then on impacting the mother's sleep? And then actually, how did those two kind of interact with each other? So we're looking kind of at gestation and the effects of like stress and trauma during gestation. And then we're also kind of looking at then how that interaction of if the infant sleep is affected, what's the impact then on the family? And so that's actually kind of the approach that I took with this. And I kind of looked at the whole sort of picture and that interactive effect. And so this is a fairly new area of study. And so we don't probably have quite as many papers on this as we do maybe in some other areas. But I think especially now, considering what's been going on with COVID, I think actually, we're starting to see, it's like I was just doing a webinar last week, and they were actually saying, it was out in California, and they were saying that, their state stats and their, for the stats for their county were finding a big increase in preterm birth during COVID. And that's actually not surprising. The physiology of that is not surprising at all, because when people are under a lot of stress, it increases inflammation, and those inflammation molecules, among other things, ripen the cervix. And so you can draw a direct line between inflammation, stress and inflammation and preterm birth. You can just draw a line right like to those. Now I'm gonna toss in just one other thing, because I just think particularly during this time, I think this is an important kind of preventative thing, and especially thinking about the mission of the organization, that I'm speaking for today, and like looking kind of globally at kind of like all these different areas of effect. And we also know, what the devastating effect of preterm birth can be. So one thing that I actually just want to say is I would actually urge you to check out a Cochrane review was published in 2018 that actually found that supplementation with omega-3s during pregnancy lowers the risk of preterm birth. And I think especially now during this time when everybody is very, very stressed, that is a really critical kind of thing to look at. And actually they found the evidence so strong, they actually said, not only was it very conclusive, but they also said no further studies were needed at this time. So, that's not in this talk. I don't have a slide about that, but it is really kind of important to be kind of thinking about as a preventative. If you want to just think about with the families that you're working with right now, is this something that actually might be helpful? Because, we are learning about the impact of prenatal stress. Okay. And so that is actually something that I think is important, and it's not to lay a burden on the families, the parents, anything like that. It's to just say, okay, we're recognizing that this is actually something kind of big, and what steps can we do to kind of mitigate that? Okay. So I'm going to dive in. This is actually something that IBLC actually wants me to tell you. I don't have anything to disclose. In case you're wondering, this little chick here is my science chick. I actually have a website called the Uppity Science Chick. So this is my little science chick here. Okay, so let's talk a little bit about kind of that link between kind of sleep problems and kind of like particularly like in that sort of perinatal year, how they can actually impact each other. One thing that I think is really kind of important to acknowledge is that, sleep disorders are something that are extraordinarily common in most psychiatric disorders. So it doesn't matter if you're looking at men, if you're looking at women, if you're looking at children, that you really see kind of across the board, that if you are depressed, it impacts your sleep. If you have PTSD, it impacts your sleep. Anxiety disorder certainly impacts your sleep, and it impacts it in some pretty specific ways. We know that it actually changes the total length of time of sleep. It also tends to, govern things like night waking, not getting enough slow wave sleep, the real deep sleep, because again, like I said, if, all of these psychiatric conditions reflect a state of hyperarousal from a physiological standpoint. So it is going to actually impact the ability to kind of relax and go into deep sleep. And so then that has a lot of repercussions. It has a lot of repercussions for how people function during the day, but then it also reinforces the symptoms, unfortunately. And a lot of times, what we found in studies of PTSD and sleep is like, if you can actually address the sleep problems, oftentimes the symptoms of PTSD get better. So there is definitely a very clear link. And you also see this with things like bipolar disorder. That's actually kind of one of the hallmarks. And in fact, many of the moms that I interviewed for my first book who had postpartum psychosis, the thing they all had in common was 2 or 3 days of no sleep before they had the psychotic break. So again, like I said, there's just this critical link. And the reason I mention that with bipolar is because bipolar disorder is the most common underlying condition, with postpartum psychosis. Okay, so it is something you see just kind of across the board. So sleep is a very, it's very predictive of psychiatric disorders, and, it's a very common symptom to see. Okay, and so one of the things that's actually kind of important to also recognize is that there is this sort of like, bidirectional relationship between what happens with things like depression. Now, that's what we have the most research on, but you see the same kind of similar pattern with PTSD and also with anxiety disorders. But that depression, particularly, we know more about this, really not only compromises like the sleep quality. So if somebody's depressed, it actually changes the nature of their sleep. But then the other thing is that goes the other way around. but then the sleep problems then compromise the mental health. And so it gets into this very bad reinforcing curve, where it just kind of goes around and around and around, and what's, depression, I've already kind of mentioned a couple things it does. It tends to shorten the total length of time, tends to actually increase the number of minutes that it takes to get to sleep. And it also reduces the amount of slow wave sleep. There's a pattern that you see in depressed individuals where it's called reduced REM latency. And basically what that means is, as you're going through your sleep cycles over the night, you're kind of going back and forth between the REM sleep, which is the more active brainwave pattern, and the slow wave sleep, which is a longer wave, as the name implies, a slow wave. It's like it's got this long kind of wave. That's the deeper sleep. And oftentimes you have more slow wave sleep at the beginning of the night, and then REM actually just a little bit, and then it changes, and then you get more REM and just a little bit of slow wave. And so what happens actually in depression is it's basically a lopping off of that first part of the night where you have the long stretches of slow wave sleep. And so it goes more quickly into the long stretches of REM. And so that's why they call it reduced REM latency. It means it's a reduction in the amount of time before REM becomes the predominant state. Okay, so basically what functionally that means is you're not getting slow wave sleep. And that causes all kinds of problems because, for one thing, when you're not getting slow wave sleep, you're more fatigued during the day. The other issue with no slow wave sleep or lack of slow wave sleep is actually you have more bodily pain. Because, like if you look at some of the chronic pain syndromes, particularly fibromyalgia is one that this has been connected to. People, think, oh yeah, that's just a psychiatric condition. There's no physical things that go with that. Well, it's actually not true. It depends where you look. If you look at like things like sleep studies, or if you look at things like cerebral spinal fluid, you actually do see physical markers. Okay, but one of the patterns you see in fibromyalgia is this basically a lack of slow wave sleep, that a more active pattern intrudes and superimposes over slow wave. So basically it's no slow wave sleep. And so that's what happens. It's like if you, like knock yourself during the day or something like that, you get these little sort of micro traumas, we call them, where you pull a muscle, or you smack, your leg into the table, things like that. Those actually normally get taken care of if you actually get some slow wave sleep. Our body heals them. But if you don't get that, then you actually have pain, and it like increases. And so you have two things that reinforce then depression. You're more fatigued during the day, which makes you feel more depressed, and you have more pain, which also makes you feel more depressed. So you can kind of see how that goes. And so like if you're depressed, it's already changing the nature of sleep. It's one of the reasons why it's really important that we don't just run in with somebody who's depressed and say, oh, I know what we need to do. Let's just take the baby away, because the chances are it's not going to help at all with the sleep. And actually it's probably going to aggravate things, because then you're not getting the protective effect of being with the baby, especially if you're exclusively breastfeeding. Okay, so let's keep going. Okay, so this was actually an interesting study. It was actually showing in a sample of predominantly kind of older white women. Okay, and that's kind of just important because you're going to see more breastfeeding in that sample. But they were actually looking kind of specifically at the link between sleep disturbance and postpartum depression. And they've said kind of across all these different studies that they actually found a strong relationship between sleep disturbance and postpartum depression. So just to say, this is something that does show up in studies. It's something that you think, okay, it seems kind of obvious, but it's good to actually have the research background, because sometimes, honestly, the looks can be deceiving. Okay, same thing here, strong correlation between fatigue and depressive symptoms, looking at the first 2 years. But what's interesting about a lot of these studies is they really don't often include the feeding method, and I said, I know you had James McKenna come and talk in February, and it's like, that's something, especially he's done a lot of sort of groundbreaking work on that. But one of the things that's really critical to know is that feeding method actually absolutely impacts sleep, and it's like, and it impacts it in some ways you wouldn't expect. And so you really can't include and talk about sleep with a breastfeeding parent. You actually cannot talk about sleep without actually talking about how they're also feeding, because the answers aren't going to be the same. And particularly when you're talking about somebody who's exclusively breastfeeding, you can't actually avoid that. And so it's kind of like, if you start messing around with that and saying, okay, you should need to sleep a stretch of 6 hours, and you interfere with exclusive breastfeeding, you actually lift some of the protection that exclusive breastfeeding is providing. Okay, so this was actually kind of an interesting study. This is actually out of the University of Michigan, and they were looking at what are the things that actually transmit intergenerationally post-traumatic stress disorder. And so they found there were actually two different things in this study that predicted. So these are women who had PTSD during their pregnancy, or they had kind of pre-existing and then they had PTSD during pregnancy. And these are the things that predicted whether the baby then would go on to develop later symptoms of PTSD. And they found there were two things that actually made a difference: infant sleep difficulties and maternal depressed mood. Okay, and so these things a lot of times are going to be related to each other. But what's interesting, and I actually have a whole other talk on this, but what's interesting is these things are things that get addressed by breastfeeding. This is one of the reasons why breastfeeding actually does help, because it actually addresses both of those. But let's say you don't have that, then what's going to happen is that are the infant sleep difficulties and the maternal depressed mood going to keep going on? And then that next generation gets post-traumatic stress disorder. Okay, now I thought this was a really interesting study because, first of all, they did it with mostly lower income families, and they racially diverse. So a lot of times you don't necessarily see that in some of these studies. And it was interesting. Of course, you see the same pattern. And so, that's kind of reassuring because, again, like I said, there's always kind of the question about, should you generalize things that are taken from, sort of white middle class families and try to apply them to other groups. And in this study, it actually is, pretty consistent, which I think is nice. But what I like about this study is it actually kind of longitudinally looks at that relationship between fatigue and depression. Okay, and so they actually did stats that actually allowed them to make causal inferences, which is nice. People say, oh, you can't just say cause by that, but you can if you do this with this type of design and with the longitudinal study. So here's what they found. They found, first of all, if they had depressive symptoms, okay, I think they were looking at this point at mothers. If mothers had depressive symptoms at 1 month, then the sleep quality actually was compromised at 6 months, again, in the mom. Okay, which led to more depressive symptoms at 6 to 12 months. And so again, you can kind of see that cycle. So you see depression, which compromises sleep, which increases the risk of depression. Okay, so that nice little cycle. Okay, so just a couple of sleep terminology things. I talked a little bit about a couple of these already, but sleep latency is a term that kind of we use when we talk about sleep, and we talk about it's the time to get to sleep. This turns out to be a little bit critical especially when you're talking about perinatal mood disorders, because it's very predictive. Anything under 20 minutes tends to be fine. 25 minutes and above actually tends to be very highly predictive of postpartum depression. And sometimes I've had, if families, they'll say to me, they say, oh, well, how can you how can you even tell how much you have, and it's like, if a mom says that to me, then I kind of know she's probably fine, because it's the mothers that know exactly how long it takes because they're sitting there staring at the clock. Those are oftentimes the moms that are at higher risk. Okay, but also sleep efficiency is another one. It's basically the total time spent minus total time in bed. So it's kind of like, oftentimes, you can sometimes, especially if you have insomnia, you can be in bed actually for several hours beyond what you're actually sleeping. So what we need to kind of get a sense of is, how much of that time in bed is actually spent sleeping. Okay, so we know some things. This is actually a study looking at postpartum depression, and actually it shows you a couple of things about kind of like sleep. And I think that this is an important one. I use this sometimes to guide kind of clinical advice, because this is kind of one of the things they found that the mothers were, if they had depression at 3 months, were more likely to sleep less than 4 hours at a stretch. Okay, and they tended to nap less than 60 minutes during the day. And so again, I think this gives us some guidance, because, when people say, oh, you need to have a 6-hour stretch, well, not necessarily. I think actually, honestly, a 4-hour stretch is going to be better, and it's not going to tank breastfeeding, because again, like I said, we really need to kind of know where the mom is in terms of her goals and what she wants to do. And if she wants to continue exclusive breastfeeding, let's not sabotage that, because that's going to actually be very protective of her mental health. Okay. And so, and I'll show you some data about that in just a bit. But, if we can go for a 4-hour stretch, oftentimes that's going to be enough to make a difference. And probably a lot of you actually can remember a time when you felt so exhausted that you didn't think you could actually even go on. And then you managed to get a 4-hour stretch. And the next day, just everything felt so much better. You just felt like you were born again the next day. It was a total difference. And again, this is kind of where the social support, and we can talk a little bit about kind of how we can actually accomplish that. Okay, so a study from moms in Taiwan actually found sleep of depressed mothers. And again, very, very consistent. We found this sleep latency. So longer sleep latency, remember 25 minutes, or you're in the depressive range. But they also, as I said, tended to sleep a short amount and not surprisingly had more daytime dysfunction. So you just see this pattern kind of popping up in study after study from all over the world. Okay, so this is another one here that was published in Joggin, and they actually found also too, depressed women had longer sleep latency, it took them longer to get to sleep. They tended to actually wake after sleep onset. And again, this is not related to feeding the baby. This is like they pop up and everybody else is asleep. That's really characteristic of depression kind of in general. Okay, and also to poor sleep efficiency. So it takes them longer, in bed to actually get some sleep. Now, I think this one's actually really quite interesting because oftentimes the solution that is proposed is take the baby away, have somebody else take care of the baby. And realistically, a lot of families do not actually even have that as an option. And we even asked in our study, and I think it was like 18% said they had somebody to help with nighttime feedings. I mean, seriously, that's not very many. But this one's interesting because the babies are in the NICU. Okay, so the babies are actually taken away, and yet there's still sleep problems. Now you could say yes, but the mothers and fathers actually, as it turns out, were worried about this babies. But they actually, I said, and that's true. That's 100% true. But you would think that there would be like, based on the theory that if you take the baby away, it's going to get better, that there would be more sort of even sleep. And in fact, there wasn't in this study. So they were finding actually, sleep problems. You said, for 93% of the mothers and 60% of the fathers, they had difficulty falling asleep. So sleep latency. They woke during the night. They had a total lower sleep time for the mothers, not for the dads. So again, like I said, this was a study with parents, who had their babies in the NICU in San Francisco. So this is actually something that Goyle said, and I think actually she kind of summed up a lot of this research. She said, for many new mothers, a complaint of trouble falling asleep may be the most relevant screening question in relation to the risk for postpartum depression. And I think actually really it's kind of an interesting question to ask because, sometimes if you come straight out and ask questions about depression or anxiety or something, parents may actually go to some length to actually convince you that that's not an issue with them. But because they're embarrassed about it, and they don't want you to kind of know. And in some cases, they may worry that you may swoop in and take their babies away, so it's like they may not want you to know this. But what's interesting about asking about how many minutes it takes to get to sleep is it kind of bypasses some of that defense and it really will give you a true picture. And it's not something you necessarily need to say, oh, aha, yeah, see, I knew it. It's more like, that's a piece of information. And now let's kind of see what else, we can kind of gather. It's just a piece of information to kind of put in your head. And then as you're working with this family, then you can actually kind of see how this actually fits in with everything else you're learning. Okay, so does maternal depression affect infant sleep? Okay, and so this is actually looking at, this is a study from Tiffany Fields, and she was looking at pregnant women. And so 83 of them were actually depressed. And so then in the offspring, in the infants, she found then after birth, if the moms were depressed during pregnancy, that the babies had higher norepinephrine and higher cortisol levels. Okay, and that newborns of depressed mothers had more sleep disturbances and less sleep time. And again, like I said, it kind of reflects, if the mother is depressed, there's going to be this state of hyperarousal, and it seems to actually get passed, and an activation of the stress system, which seems to get passed then to the infants. Okay, and it's the entire stress system. So we're looking at the catecholamine response, which would be in the norepinephrine, in the cortisol, and you'll see some other studies that look at inflammation. So it's the entire stress system in the infant gets activated. I think honestly, this is where you start getting epigenetic effects, so across generations. So like, for example, you look at obesity stats, and you can see these intergenerational effects. You can see these effects of intergenerational traumas, for example, that have happened. And so, if whole cultures are sort of plunged into a situation that's highly stressful, you can actually see that then the offspring oftentimes come out with that sort of starvation effect activated, which means, okay, food is scarce, I better hang on to every single calorie. And you can actually see how over generations that would actually really kind of increase. And so then when you start comparing it to, rates of obesity by different groups, you can actually see a pattern. I think honestly, you can see a very clear pattern of slavery. You can see it in the US and you can see it in the UK, which is two places I've looked at it. You can see effects of colonialization. You can see effects of, you look at this also by income, it comes at the same thing, but it's the same sort of hyperarousal pattern. Okay, so again, not surprisingly, you do see that. Okay, so this was another one. This is the big ALSPAC study that's actually been done in Britain. It's been going on for a long time. Big longitudinal study there. They had, I think, 24,000 in the total sample, so it's good size. No, 14. Excuse me, it's 14,000. But I thought this was interesting because they were looking at this and they said, well, that antenatal depression or depression during pregnancy was related to more night wakings at 18 months and shorter sleep duration at 24 months. Okay, so if the mom was depressed during a pregnancy, this is actually kind of what happened. But they also said that there was actually what they call a triple interaction. So it wasn't just the mother's depression that was a variable. It was also sex of the infant. And it was actually, and I'm actually using the way the language that they use it, sex versus gender. Gender is actually the acting on and the expression of sex, but sex is the biology, and that's what they were looking at. Okay, so they were looking at the sex of the infant, and they were also looking at the temperament. And so they were looking at the babies who had the quote high needs, or the, as the research sometimes says, the difficult temperament, but the sensitive where they're more sensitive. And so they said that those were the infants that were the most affected by this. So if you had maternal depression plus a male plus plus a more sensitive temperament, that those were the babies that were the most susceptible. And it's a big enough sample that they were able to sort of tease apart those differences. So you see, it's not just an across the board. If mothers are depressed during pregnancy, you're going to see this, but it could be that there's some other vulnerability factors that the infant then brings to the table. Okay, another one here looking at full-term infants. And so it was half and half in terms of depressed versus non-depressed. But they did find that the maternal depression did alter the sleep structure in infants of depressed mothers, which included more awake time, a smaller percentage of non-REM sleep. So that could be things like the lack of slow wave sleep, and a less total sleep time. So you can kind of see how also too, there could be some vulnerability factors on the mother's standpoint too, that maybe she's very susceptible to lack of sleep. And so you could see how this could be a real mismatch between, the mother's needs, and the baby's needs. And, actually, honestly, you could see how this could actually impact the whole family. Okay, so as I said, modifiers to these effects. Okay, male sex, they found the same thing. The reactive temperament and the mother's expectations about infant sleep. Now, this is an area I think where we can actually intervene, and say, okay, because sometimes I think people have some pretty unrealistic ideas about how much babies will sleep and how quickly they will get into a schedule. And particularly sometimes babies that are, the late preterm babies, they look like kind of full term, but they're not. They actually a lot of times have some pretty significant sleep difficulties. And if you've got an unrealistic expectation about this, and then that just really is one of those things that just sort of builds. So we can actually talk to families about this. But they also said the goodness of fit. So in other words, if you have a mom who's kind of laid back and her baby's got this kind of fussy kind of, high needs sensitive temperament, that could work. But what if your mom is kind of a little bit high strung herself, mom or dad, family member, other family members, kind of like a little bit high strung, and then this baby's crying? You could actually see how that would not be a good fit and how that would be a problem. And so that's part of it too. This is like, what do the parents bring to the table? Okay, so this is another one. They looked at mother-infant dyads. So they assessed prenatally, and then they looked at 4 times postpartum. And they also looked at that idea of goodness of fit, a mother-infant sleep, and the relationship to postpartum depression. And they found that it didn't, the infant sleep patterns just by themselves didn't contribute to the depression. So that part I thought was actually kind of good news, because what they were looking at is, if you've got these babies that were sensitized by the depression antenatally or prenatally, and they're sensitized and they're not kind of sleeping very well, is then that reinforcing the depression in the mothers. Okay, and they didn't find that in the study. But they did say, again, this goes where that mother's needs kind of comes in. If they were, people, because I mean, we vary in terms of how much sleep we need to feel good. And they said if they required more sleep prenatally, they were more affected by it, than mothers who maybe could sleep less. So if you're somebody who needs like 8-9 hours of sleep a night, this could be a problem. But if 6 is actually good for you, which is actually kind of, that's on the low end of normal, that actually you'd probably be able to roll with this better. Okay, I think that's what they were kind of getting at. Okay, so they said it was the combination, then looking ahead to 30 months, it was the combination of the mother's prenatal sleep, the infant sleep, that actually could indirectly affect mother-infant attachment. Okay, and so that is, to me, kind of an ominous symptom. And that's, again, a place where I think we probably need to intervene. Is this idea of, okay, can we do some education so families have a realistic expectation? And also, what are some ways to kind of cope with a baby with these kind of more sensitive temperaments, and what can we do? And if you've got, sort of parents that are all of a sudden feeling they're kind of impaired because they've got depression or PTSD, you can kind of see how they would actually, the whole family's really going to need some extra support, because otherwise then what could happen is an attachment, like a, insecure attachment. And then that has lots of ramifications. Okay, so another study looking at pregnant women in Melbourne, Australia, and they actually found that both maternal depression and antidepressant use were not related to infant sleep problems. So some of the studies have found it, and this is exactly an example of one that did not find that. And they didn't find that infant sleep problems they were not associated with maternal depression. Okay, so the infant sleep problem didn't seem to cause more depression. Honestly, I think that they could, but I think it could be that if there's more of the vulnerability factors that we talked about, so I'm going to say, probably based on all of these studies, I would say, do infant sleep problems cause problems then for the parent? And I'm going to say they could, but they don't always. Okay, but this was actually, and I found this a little disturbing, actually, this finding. They said that mothers' beliefs about setting limits at night was related to nighttime infant signaling. In other words, I think this was, advice to ignore infant cries at night, which I'm not a fan of. Okay, and so again, like I said, that, I've heard people kind of talk about this, that this is kind of important. But, on the other hand, I actually look at the whole set of data about the impact of exclusive breastfeeding on mother's mental health. And so I don't, this is not something I advise. Okay, but they did actually find this, so I have to report it. Okay, so where does breastfeeding fit into this? I've mentioned it a bunch of times because it is so, woven into this. Okay, let's take a look at some studies. This is actually one that I really like a lot. This was actually came out in a sleep medicine journal. And what I actually find kind of interesting about this is, it's not something that was supporting breastfeeding, necessarily, but they were just looking at it as hardcore sleep researchers. And so you see they had a pretty decent sized sample. And they did actually find that the mother's poor sleep was a risk factor for depression. Okay, but here are the factors associated with poor sleep. Depression. Okay, so depression impacts the sleep quality. Absolutely. Previous sleep problems. This is something that a lot of times we've never even asked, when we're talking to, parents about, like, how you doing and how you coping with this. And we've never really found out, do they actually have sleep problems? And so it's probably a good question to ask. If they're first-time moms, a lot of times they were having more difficulty, a little more anxious, not as kind of relaxed about things. This also, too, finding the male infants actually to be more sensitive, but also younger. And this is probably speaking to the late preterm babies. I said they're notoriously poor sleepers. I think part of it is because they don't get enough calories when they eat, because they fall asleep before they finish a full feed. So we can kind of talk a little bit about what are some things that you can do about that. Okay. And so they tend to not be very good sleepers because they wake up all the time because they're hungry, because they didn't get quite enough to eat. But also we talked about male infants being a little more sensitive and also a little more vulnerable. They have higher rates of SIDS. It's not a huge difference, but it is a difference. Okay, but here's the interesting thing about this. The families actually that were not exclusively breastfeeding actually were the ones that had the risk factors associated with poor sleep. Okay, so in other words, the exclusively breastfeeding mothers actually in this study actually had higher rates of depression. So if they were not, the lower rates of depression, the exclusively breastfeeding mother had lower rates of depression, that was protective. And so this was actually one of the first ones that really actually found that difference. Okay, now this was actually a study from Crete that I thought was kind of interesting because they found a few sleep factors that were prenatal that were actually predictive of postpartum depression. So they found a couple of sleep patterns during pregnancy. So they said if the mother was sleep deprived, or if she snored. But sleep deprivation in pregnancy, I thought was actually a real interesting one because it increased the risk of postpartum depression by 3.5 times. Okay, so that's a really big jump. But snoring during pregnancy increased the risk by 80%. So that's actually also something interesting because again, we don't usually ask, families about this. We don't usually ask parents, what was your sleep like during your pregnancy? What was your sleep like before you got pregnant? But I thought this was also interesting too. And I actually kind of use this. I've been just finishing up a book on breastfeeding. And I use this actually as kind of a thing because it's like we have data that actually show that if you start breastfeeding and stop earlier, that if you stop before 8 weeks, you actually tend to have higher rates of depression. And we've had several studies that have actually shown exactly the pattern, and this one did too. So that if breastfeeding duration was less than 2 months, you actually were significantly higher risk for postpartum depression. Okay, so I want to actually show you a bunch of our data. So many of you are familiar with the study. So 6,410 moms, we did an online survey. And so we had this big, survey of mother sleep and fatigue. We asked lots and lots of questions. I'm still analyzing data from it because it was such a rich data set. But they ended up representing 59 countries, which actually really surprised us. We were not expecting that, honestly. We expected US, Canada, UK, Ireland, Australia, New Zealand. We didn't necessarily expect all these other countries. So I'm kind of glad we didn't limit, our choices. We had a drop-down menu where people could list. And yeah, it was a big amount from all over the place. And really, not surprisingly, the biggest contingent was in the US, but we had a good spread of income levels, because we actually really recruited through our WIC program. And so we actually had, income kind of across the board, but the sample was very highly educated. So it was about 73% had a bachelor's degree or higher. So, again, like I said, in that measure, mostly middle class. Okay, so what's interesting is, we looked at a couple of the variables that probably make people think that stopping breastfeeding is a good idea. Okay, and again, like I said, if you were to just look at these, you would say stopping breastfeeding is a good idea for the mother's mental health. Okay, but that's actually not what we found. Okay, and so I'm going to show you these two, and then I'm going to show you the rest of the set, and I think it'll be surprising. Okay, so the first thing we found is the total number of hours that the baby sleeps the longest stretch. And you can actually see that the exclusively formula-fed babies slept by far the longest, and the exclusively breastfed babies down in the blue actually slept the shortest amount of time. Now, when we actually did the post hoc analysis on this, where we actually got in and analyzed, the nitty-gritty of the data, something we found in this data set that absolutely stunned us was that there was no difference between mixed and formula feeding, at least on these variables. Okay, for other things, obviously mixed feeding is superior to formula, exclusive formula feeding, but not for these things that look at maternal sleep and also maternal mental health. Okay, so that's actually where we didn't, where the real difference was in terms of these protective factors. And I think actually the physiology of this is such that it actually makes a change. So we didn't find any significant, it looks like there's a difference, but actually when we did the post hoc analysis, when you analyze things like how the curves overlap with each other, there was no significant difference. That surprised us, honestly. We were really surprised, but it was consistent. We found it across the whole thing, and other studies have found the same thing. So I think we found something. So you can see there, you think, okay, so if you looked at just this, you think, well, it would be better to exclusively formula feed. And same thing here. If you look at total number of nighttime awakenings, the exclusively breastfed mom is up a lot more. Now, I'm sure when Jim McKenna was talking to you in February about this, he was saying this is protective for the babies. It is, the fact that they're not sleeping for a long stretch and that there's more nighttime awakenings. He says this is protective because one of the big theories of SIDS is that babies go into such a deep state of sleep they can't rouse. Okay, so the frequent nighttime wakings and having a parent there who's attentive to them and paying attention and waking up, and same thing with not sleeping a long stretch. Okay, so both those would be protective. But you'd say, but we're talking about mother's mental health here. We're talking about the mental health of everybody in the family. Okay, so then we start looking at some of the ones that are related to mental health. And what's interesting about these is that, again, we found the same pattern of the exclusive breastfeeding was different than mixed and formula feeding, that they were not different from each other. Okay, so there's two variables in sleep that are actually related to depression, that are predictive of depression. The self-report of the mom, how the total amount of time that she sleeps, and also to the the amount of time it takes her to get to sleep, the minutes to get to sleep. Those two are predictive of depression, and both of these were actually really consistent with being protective. Okay, so no significant difference between mixed and formula, and the exclusively breastfeeding mother slept more. Okay, now that just seems totally kind of mind-blowing considering those other two slides. She's waking more and the baby's sleeping a slower stretch, and yet she's getting more sleep. And it was really consistent with all the other variables that we looked at, including things like the mother's daily energy. You can actually see here, that it's significantly different. The mixed and formula feeding is actually, significantly lower. Now, I would like to point out something that I think is really important. This is actually a 5-point scale, because sometimes people say, well, I breastfed and I was tired. Well, yeah, honestly, everybody's tired here. But the question is, if you started supplementing, would you be more tired? And I think, honestly, the answer to that is yes, you would be. Okay, and so remember we talked about minutes to fall asleep. Anything under 20 is considered good, and above 25 is actually high risk. Remember, it looks like there's a big difference here, but there wasn't between the mixed and the formula feeding. They were not significantly different. Okay, and then that translated into the risk for depression. So this was looking at current depressive symptoms. You can see the exclusively breastfeeding mothers are quite a bit lower. Now, they still have some, not everybody. We talk about, how this lowers risk of depression, but it doesn't eliminate it. So you can actually still have exclusively breastfeeding mothers who are depressed. In fact, that's the group that I have worked with the most throughout my entire career. Okay, so sometimes people misunderstand what I'm saying here. I'm not saying it eliminates risk, but I'm saying it lowers it, and it lowers it substantially. And particularly if you're talking about somebody who's already kind of experienced depression, who has actually maybe been depressed or had PTSD or anxiety during pregnancy, then the exclusively breastfeeding, actually, we've got a nice new study just came out this year, showed that it actually lowered the amount of depressive symptoms. So in people who are already depressed coming into postpartum, that exclusive breastfeeding lowered their depression. That's fantastic news. Okay, and also too, looking at things like the rating of their overall physical health, did that actually make a difference? I'm just checking the time here. Okay, and so then also too, let's take a look at the impact of sleep location. Now, this one was kind of interesting because, you saw our data on just looking at the feeding method, but, we had some people that questioned, well, does it make a difference where the baby sleeps? And the answer actually is yes, and it came out in some surprising ways. Okay, so what was interesting is, by this time we went ahead and collapsed the mixed and formula feeding into the non-exclusive breastfeeding. So we just were doing a comparison. We did that because they weren't statistically different from each other. Okay, and it shows, I think, a rather clear pattern. And one of the things that really sort of jumps out, if you take a look at some of in the sample, these mothers who were exclusively breastfeeding, no matter where their baby slept, they had lower risk of depression. But the group that actually had the highest risk of depressive symptoms, or the highest depressive symptoms, were the non-exclusively breastfeeding, non-bed sharing mothers. And again, I said, this is exactly the advice they get, isn't it? Oh, don't exclusively breastfeed. You don't have to do that. A lot of times it's recommending skipping nighttime feedings and stuff. And don't bed share. Have your baby out. And usually, oftentimes it's recommended to have baby in a different room. And that actually seemed to cause the most depressive symptoms. So again, like I said, we really have to question, especially when you've got a big sample like this, we have to question the sort of the accuracy of that advice, honestly. And also too, this was actually also really interesting. It's like, should you bed share if you're not exclusively breastfeeding? Now, I know Jim McKenna talks about this in terms of infant safety, but I'm going to talk about it in terms of safety of the mother, which is in this sample, what we have. And you can actually see, look at that. Guess who has the most anxiety? It is the bed sharing, non-exclusively breastfeeding mother. So for that mother, with the, if she's highly anxious and she's not exclusively breastfeeding, should she be bed sharing? Probably not, honestly. You want to have the baby close because, you still have to attend to nighttime needs, but should you be bed sharing? Probably not. And I think this was actually really interesting too. Take a look at this. Of course, the bed sharing exclusively breastfeeding moms are the ones who get the most sleep by far. I think that's not a huge surprise. But look who gets the least amount of sleep, non-exclusively breastfeeding, but bed sharing moms. This group here, they just really have some problems, and it's funny because it's like, I've heard this from clinicians for years who say, well, the mothers I work with who are bed sharing, they have more anxiety, more depression. I'm kind of like, no, 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 no. Because overall in the samples, it actually shows kind of the opposite pattern. However, when we broke it out, I could actually see that you could argue that there are two groups here. The ones that are exclusively breastfeeding are actually getting benefit out of this. The ones who are not exclusively breastfeeding are not, and so that could actually be why some, clinicians who work with perinatal mental health disorders see this, but people who work in the broader breastfeeding world don't. And I think it's because we're looking kind of basically at two different subgroups. Okay, look at anger and irritability. Who is the most grouchy? I mean, can you kind of see why? I can kind of see why, baby's kind of routine, not going to sleep. I can kind of see why this would happen. Okay, so let's take a look at trauma and PTSD on mother-infant sleep. Okay, so first of all, I just want to really kind of show you that trauma is extremely common. I'll show you a couple different studies about this, but this is actually from our data. And actually, we're just kind of getting back into, I want to analyze, this in more kind of fine-grained detail and look at supplementation and stuff. But we had 994 women in our sample report that they've been raped. This is the largest sample of sexual assault survivors, in a perinatal study. We just have a really big sample, and it reflects an unfortunate reality, in many, many parts of the world. 25% reported childhood sexual abuse. That's exactly what the data predict. Okay, that's exactly what it says in the literature. So we were right on there. 32% reported that their parents used substances. 34% reported that they had experienced physical abuse, and 36% reported parental depression. Now, these are all part of the adverse childhood experiences study questionnaire. Okay, so that's where these came from. So that just gives you an idea. This is really common. I mean, and in a sample that is largely middle class, this is the group everybody says, oh, this doesn't happen in. It's like, no, 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 no. Okay, and we can talk about the impact of pregnancy and adversity and violence, and just kind of want to recognize that violence a lot of times is not the only thing that's going on, in a situation where there's a lot of times complications. Okay, so a lot of these things are kind of, I would call prenatal adversities. Violence, it would be certainly a very significant one of those. Just to kind of give you some ideas, looking at a low income versus a very affluent community. These are two communities in Boston. You can see the rate of prenatal depression is, twice as high in the urban inner city population, as it is in the affluent suburb. But I thought this was actually really interesting. I apologize for that being kind of white and hard to see, but the rate of lifetime abuse, okay, and here is actually significantly, it's high in both. It is different in the inner city population. It is higher, but look at that. It's almost half in the affluent suburbs, so don't ever let anybody convince you that this doesn't happen pretty much everywhere. It does. Okay. And so this is actually the study I was mentioning earlier that talked about prenatal adversity. Okay. And how it actually impacted, the offspring. Okay. So this was actually a longitudinal study. And so you can kind of see this is by age 42, that if people, that if their mothers had experienced prenatal adversity, that the offspring, actually had an increased risk of inflammation, high C-reactive protein. It increased their risk by 3 times. Okay, so C-reactive protein is the inflammatory compound that actually shows up a lot of times in primary care settings, and it's really predictive of things like heart disease. Okay, and we can see kind of the rates of prenatal post-traumatic stress disorder. This was kind of a big meta-analysis looking, so 24,000 mothers in this study, and they found, about 3% for prenatal and 4% experienced postpartum PTSD. However, they said in quote high-risk groups, the rate runs about 18.5%. Now, they were really vague about what constitutes high-risk group, but I mean, you can actually kind of imagine what that is. And so again, there's a lot of people with PTSD during pregnancy, okay, or immediately postpartum. Okay, and so again, rates of acute PTSD, this is another study, this is from Sharon Deckel at Harvard. She found the rates, so during kind of postpartum between 4.6 and 6.3%, yet about 17% had clinically significant symptoms. Okay, so basically they found that postpartum PTSD was related to all sleep variables except for daytime sleep duration. Okay, so again, like I said, the mother's PTSD level. So this is where you start talking about even things like, the experience not only of violence, but you experience the effect of things like birth trauma. Okay. And so that actually really does that, it impacts the mother's experiences like it did in this sample, but then it also impacts what the infant is doing in terms of their sleep. Okay, so this is another group a lot of times people always ask me about is sexual assault survivors. And so again, like I said, because people, especially with talking about breastfeeding, they're like, what about this group? You can't force them to breastfeed and everything. Well, as I said, we had a large sample of sexual assault survivors. And so we looked at all the variables that we had just kind of looked at with regard to sleep. And you can see that there's this pervasive negative effect. If you identified yourself as a sexual assault survivor, that it impacted pretty much everything. Now, remember, a lot of the group in the blue, the non-sexual assault group, reported other adversities. Okay, so this isn't even a sample of, in a comparison to people who had experienced, very little in terms of, lifetime trauma. These are people who had experienced trauma, and yet you still see this big pervasive negative effect. Minutes to get to sleep were higher. They're right there in that depressive range. They tended to report their physical health as being poorer. Okay, and also the current depressive symptoms were higher, and same thing with anxiety. Anxiety was actually quite a bit higher. Okay, so again, like I said, you see this pervasive negative effect. Okay, so does breastfeeding help with this? And so that's when I decided to put the feeding method in with the sexual assault status to see what we could see, in terms of did it make an impact. Now, we know that actually breastfeeding is a powerful physiological mechanism that actually downregulates the entire stress system, including the inflammatory response. Okay, but you only get that effect for exclusive breastfeeding. That's really where you see it. Okay, so I was wondering, with this group who had experienced an extreme trauma, would we see a difference? Okay, so the first thing that I thought was actually really interesting is that the sexual assault survivors actually breastfed at exactly the same rate as the women who were not assaulted. And so again, like I said, that's surprising to people because a lot of times people think, oh, well, they want to jump in and tell, people, oh, you don't have to do that. Don't worry about that. You don't need to, you don't need to breastfeed. And I think honestly, that is actually really being very paternal and really kind of in some ways taking away their rights. I've actually worked with lots of sexual assault survivors, and you know what? You kind of go with whatever they want to do, and it's like sometimes exclusive breastfeeding is not on the cards, and that's fine. We just work with that. Okay. But let's not stop them because, oftentimes, now they may experience difficulties doing this, but oftentimes it's an important goal. I've talked to women who've actually said, I never liked it, but I did it for 4 of my kids. And I asked this one mom who said that to me one time. I said, why are you doing it? She said, because it's important. And she said, and I was determined to do it. So she found a way to cope with it. And so again, not everybody's going to report these sort of rosy experience about it, but they think it's important. And so again, like I said, these are really, I think, pretty high rates, and is it identical to the other group? Okay, so this is actually, these data were something that I was the most excited about of anything I've ever seen. When this stuff started popping off my computer the first time, I actually couldn't believe it. Okay, so let's look at all the factors that predict things like depression. Okay, and so this is what I'm saying, that exclusive breastfeeding actually really has to be included in the mix when we're talking about any of these effects. Okay, so, you can see the green line are the exclusively breastfed. We went ahead and combined the mixed and formula feeding. Look at the total number of hours that they sleep. Okay, it is significantly higher. And in fact, even for the sexual assault survivors, their sleep is higher than the non-assaulted women who are actually mixed or formula feeding. Okay, so again, like I said, you definitely do still see an effect of sexual assault. Okay, but it seems to be lessened. And that's actually what I think is really important. And that would be what I would predict, that there would be this down regulation of the stress system. And in fact, you see it kind of across the board. So there's definitely still risk here. Okay, let's not kid ourselves, and there's some risk for depressive symptoms. Okay, but it is down regulated. Can you kind of see that? And when we look at depression, definitely an elevated risk, no question about it, but it is significantly less than it would have been. But this is my favorite one. Look at this, anger and irritability. So when we talk about things like that intergenerational transmission of trauma, and then we compare it to like Lane Strathern's study, who found actually significantly reduced child maltreatment, maternal perpetrated child maltreatment. Okay, found that in a study of 7,200 mother-infant pairs followed over 15 years. Okay, but take a look at this. Look at how chill versus that big spike up, and honestly, that's super characteristic of PTSD. Oftentimes it can be kind of like, very sort of low key, and it's like, this is what people who, are children of people with PTSD say. So I remember this one guy on the National Center for PTSD site saying this. He's talking about his dad, who was, a World War II combat veteran, probably had undiagnosed PTSD, said he'd be sitting there with the family disengaged, and next thing something would trigger him and he'd fly into a rage. And again, it's that hair trigger kind of stress response, and I think you can see that here. And what does breastfeeding do? Do you think that this could actually have any impact on how parenting goes? Do you think this could have any impact on kind of dealing with the stresses? And even if there was prenatal depression or PTSD, could this settle down the sleep? And I think honestly it could. Okay, so one of the things that's kind of interesting is to look at, I know I'm kind of running out of time here, but I will go quick. This was actually kind of an interesting set of studies, and they were looking at the impact of, did you have a secure relationship with your adult partner? So they weren't looking at, mother-infant stuff at all. But they found if you, said you had an insecure adult attachment, which meant, I don't trust my partner, I don't think my partner really loves me, that the women were reporting higher rates of daytime fatigue. So then at the end of the first study, they said, we need to really do a polysomnograph about this. And what they basically did is the second study actually did do that, the Troxel study. And actually what they did do is they found that if you had an insecure adult attachment to your partner, that you had less stage 3-4 sleep, which I thought was actually really, really interesting. So, because if you don't trust the person you're sleeping next to, are you going to be able to kind of down-regulate enough to really go into deep sleep? And so you have to down-regulate and, your vigilance in order to go into deep sleep. And so my question is, if you take babies away and put them in another room and take them away all night, are you going to get the same effect? I suspect you would, honestly. And people who've been in programs where they've done that, lactation consultants have told me that they, report that the mothers are like listening for their babies down the hall. Okay, so what are some implications? I think one of the things that's really important is that sleep is definitely related to maternal infant health, mental health. We haven't really talked so much about, there have been a couple of studies that have looked at fathers specifically with this, but this seems to be kind of a family thing. It's like, the mental health of one parent definitely impacts the mental health of the other. So, it really kind of goes across the board, but this is what the research actually is showing so far, that it is related to maternal mental health, no question. Okay. And obviously daytime fatigue is something we really need to address, and it's like, I think sometimes, and previously we've kind of been a little cavalier. Oh yeah. Parents are tired, and I think what we have to be kind of on the lookout for is the difference between tired and more tired when they get into that extreme range. Okay. We shouldn't assume that all the sleep disruptions are due to the baby, because chances are you could take the baby away and the sleep problems will still be there, particularly if they've come into the postpartum period with depression or PTSD or anxiety, or that separation is the answer. It's probably going to actually increase things like anxiety if you start, whipping in and taking away the baby. Plan of care, obviously we want to individualize it for every mother, okay, or every family, I would say that. But I think the other thing is too, I think it's really important when people are really struggling with this, is that we need to kind of provide hope that it's going to get better. And I think sometimes it's very hard when you're right in the middle of it to see that. And I think sometimes holding out a vision of hope, I think can be really helpful. I remember actually, early in my training, I was an intern at one of the very first sexual abuse treatment programs in the world. And it was a program where, lots and lots of people came. It was called Institute for the Community as the Extended Family. And they were, it was an incest treatment program. And I remember actually one of the founders of that said, and the people that were coming into that program had been seriously affected by family sexual abuse. And I remember actually the founder said, she said, the thing we need to do is really communicate the capacity for wellness. I've never forgotten that she said that, that we need to actually hold that out, that this is going to get better, and then obviously coming in and providing the support. And so many of the different organizations and the different institutional goals of the organization that is sponsoring this, I think actually really tie in well with this, and kind of if you could bring in different support and stuff for these families. And I think it's important that they know it's not always going to be this way, because sometimes it's really hard to judge when you're right in the middle of it. Okay, so just want to mention, if you're not on my Facebook page, we regularly post, and a lot of the things that we're working on PTSD and depression, and also too, I'm actually looking at some stuff with providers. and particularly now with COVID. I mean, I'm looking at the effect, particularly on birth providers, looking at secondary trauma stuff. So we've been posting some stuff about that. So if that's of interest, I would encourage you to join our Facebook page. These are all my social media pages, and I will actually make sure that you have handouts, copies of today. And there's one other thing, it's like, I know I've kind of tossed a lot of information your way. One of the things I want to kind of mention is that we've actually kind of put together a web page with a lot of resources. So if you want to know kind of what's the next step or what kind of resources are available for families, you can actually get this in a couple of different ways. For the international, for those of you in Canada, you can actually use that, either that website. If you're in the US, you can use this text number and it will actually direct you to a page, or you can scan this QR code. So in any way you can actually get to that. But what I have is a bunch of free resources, and I would encourage you, you're welcome to use them, share them, put them on your website. They're all kind of available for you for free. So I said, sometimes I know it's hard, you hear a lot of information and it's hard to know kind of what would be the next thing to do. And so that's what I actually want to just, offer you some other resources about this. And so with that, I think I'm going to actually turn this back over to Temi. Temi, you want to come back on? Or you want to do some questions?
Yeah, absolutely. Thank you so much for that awesome presentation. It kind of just went so fast. I didn't even know the time had really flown by.
Well, that's good.
Yeah, we do have a couple of questions.
Okay.
I have a few myself, but I'll start with the chat box, the ones in the chat box. You can keep the questions coming. I think we still have some time to take more. So the one here from the chat box is from Chenoa Wilson. And it says, so if I stopped at 5 to 6 months breastfeeding, is that more better than quitting at 1 to 2 months? Or am I still a high risk for depression because I was, or still sad that I had to quit because, but I was low on my supply. I had no choice.
Okay.
I don't know if you get the question.
Yeah, I do. And first of all, I want to just say, congratulations on going 5 to 6 months. That is really awesome. I want to really, just give you a lot of praise about that. And yes, I think you do actually definitely had more protection because you did that than if you went 1 to 2 months. So I would say, yes, good job. And unfortunately, sometimes, circumstances work against you, and you may end up actually in a situation where you have a low supply, and there could be any number of reasons for that. But I want to just, really congratulate you for, even with difficulties, hanging in there for 5 to 6 months. And yes, I do think that that actually did protect you. And I think actually you'll find there will be lifetime protection for you from that. Because some of the studies found, even like at 6 months, when you started looking at middle age, you started actually seeing like things like lower rates of heart disease and diabetes. So I would say, good job, congratulations. With these studies, usually kind of more is better, but definitely you did enough that you really are going to get some protection. So I'd say good job.
Awesome. Thank you. So this is from Chika Brown. It says, I'm curious if you have any thoughts on the snow. I think that's a kind of sleeping thing for a baby. Is that it?
Any thoughts on the what?
The snoo, SNOO.
Okay, so could you tell me a little more about what that is?
I'm not so sure myself. Maybe Chika can quickly type in that. While we wait, we'll go to another question.
Okay.
Also, if I'm not breastfeeding anymore, do I still have to take my prenatal vitamins? Not a question.
Honestly, I think especially now at this time, it wouldn't be a bad thing for you to do, because one of the things that's in a lot of prenatal vitamins is DHA, which is an omega-3 fatty acid. And I think that that is going to be a good thing for you now, especially during this COVID time. And especially, as we're kind of heading into winter, I think actually it would still be a good thing for you to do probably up through the first year. I don't think I think there's no harm in it. And I think in not being vitamin deficient and not being deficient in DHA, I think are good things. So I don't see any harm in it. And I think it actually probably is not a bad idea, honestly.
Great. So I'll go to the ones in the Q&A box now. Okay, I think someone is saying here, SNOO is a side-by-side rocking baby bed designed by Dr. Karp. I don't know what that is.
Oh yeah, is that the one that like kind of rocks the baby and it's got a thing that kind of straps him in?
I think so, yeah.
Okay. It seems like kind of honestly an expensive piece of gear. It's nice. I don't think there's really any harm to it. I'm not, as I recall, that there was a little bit of swaddling involved, so that I'm less comfortable with. But I think it probably keeps the baby insecure enough that they're not going to flip over. I think as long as the baby is next to you, I think that you can make that work. But I wouldn't necessarily recommend people run out and get that because I think they're kind of expensive. And I'm not convinced that they're necessary, honestly. I don't think it's bad. And I know Dr. Karp is actually really trying to create situations where babies get good sleep and mothers get good sleep, and that it's all good. So I don't attribute anything bad there, but I think actually, as long as the baby is kind of next to you and there's the protection, I think actually that's that's fine. If the baby, and again, like I said, I know that this gets kind of tricky. We want to make sure that wherever the baby is, that the baby is safe. But if the baby is near enough that it's easy to get the baby, to nurse at night, it seems to actually really have a positive benefit on mother's mental health. It's when you have to actually physically get out of bed and go get the baby and wake up and stuff. I think it's much harder to go back to sleep. Even sometimes I've met moms who are exclusively breastfeeding who were doing that, who decided they didn't want the baby next to the bed. So they had the baby clear on the other side of the room, and we're getting out of bed and, just getting exhausted. So if you're going to use something like that, I would say definitely keep it right next to the bed so the baby's handy.
Thank you. So one here says, can you repeat the orders for the study regarding omega-3s and preterm birth, or the link to the study? We would love to review that and share in my community.
Okay. Let me actually see if I can pull a
Oh,
slide
I
up.
think someone has already answered, right?
Somebody's found it. All right, good.
Yeah, I think Jody shared it. Thank you, Jody.
Good. Thank you. So
Thank
Cochrane
you.
Review 2018.
Yeah.
And I think Reedy's was actually one of the first authors on that.
Okay. I'll copy and put it in the chat box so everyone can
I would
see.
say honestly, it's like I normally kind of don't sort of butt in with this kind of stuff, but when I heard that thing about the rates of preterm birth going up during COVID, and we know we have a tool that actually helps with that, I think actually if we can actually do something about it, I think it's good for us too.
Yeah. Yeah. Okay. The next one here says, are there handouts to go with this?
Are there what?
Any handouts?
Yes, and I will send them to you right after we're done.
Oh, okay, sure. Okay, so I'll just send that in a follow-up email to everyone. That's okay. Yeah. Okay, another one here says, what about those who pump and bottle feed breast milk in addition to or instead of breastfeeding, like pumping and bottle feeding breast milk?
Well, okay, so here's the interesting thing about that. I've been asked about this for a long time. We didn't have any data on it, but it seems that actually has the same effect as having the baby at the breast. Okay. I'm shocked by that, honestly, because I thought part of it was the skin to skin contact, but it does seem like that provides protection. And I think actually that's very good news, because I think I think there's added stressors. Honestly, if I were going to kind of like, make a prediction about that, I'd say this is actually the slide with that's the slide with the reference. But I think if I were going to like make a prediction, I would say that, exclusive pumping is actually more stressful, but we do get the oxytocin effects. There was a really nice article that Kirsten Uvnes-Moberg actually just published last year. And it was in PLOS One, and it was called Maternal Plasma Levels of Oxytocin During Breastfeeding, a Systematic Review. And that's where she found pumping actually is the same kind of level of oxytocin. And see, it's oxytocin that does it, because oxytocin and the stress system are opposed to each other. So that when oxytocin is up, the stress system is suppressed. Okay, but it goes the other way too, that when the stress system is up, oxytocin is suppressed. So this is why I think this is really good for trauma survivors, because they got this hyperactive stress system, and then breastfeeding comes along and oxytocin suppresses it. And I think that's what you saw with our sexual assault survivors. Okay, but again, like I said, the underlying physiology of all of these conditions we were talking about is inflammation. And if you can address inflammation and the inflammatory response, which is part of the stress response, if you can impact that, it impacts things like preterm birth. That's why the omega-3s help, because it impacts that inflammation. Okay, so you can actually see this this is a big review article here, 19,000, and on N3 is the abbreviation for omega-3s. But I love that. More studies are not needed at this stage. You never, ever see that in a study. I can tell you that. Everybody always ends with, and we need more research on this.
Thank you for that. So someone says, what are your thoughts around medication for sleep? Also, would the goal be to ensure 1 4 hour stretch of sleep at night for parents?
I would say if you've got a parent who is struggling, okay, so I would consider this an emergency strategy. And actually, if you go to my resources that I have on the other slide, you'll actually I see that I've actually got a handout on this and talk about kind of an emergency strategy. So for me, an emergency strategy would say, let's figure that we're going to do this at least for a couple nights until things kind of more normalize. So you got somebody who's just kind of hanging on by a thread. Okay, so what you do is actually you try to get a 4 hour stretch and then you go back to having the baby near so then you can do nighttime feedings. So mama's going to want to pump right before she does this, or pump her or nurse right before she does this. And what I would actually recommend is maybe moving bedtime up early, because I think really a key to this working is having an alert caregiver. Because if you have a caregiver who is asleep, it is going to be your breastfeeding mom who's going to hear that baby first, because you're just wired that way. So what you want to have, and I think she's going to have a hard time going to sleep if she doesn't know that somebody's going to be right there to respond to the baby. So what I actually kind of recommend is that you actually start with maybe an earlier bedtime. So think about something like, say, 8 o'clock, so 8 to midnight. And so that's actually still kind of doable, because if you've got a partner who's got to go to work the next day, which is going to be the situation for a lot of families, then it's still kind of doable for them to get some sleep. Okay, so then after that, then baby's near mom, and then mom takes over. But mom, if she can get a few nights of a 4 hour stretch of sleep. And then the other thing to work on based on the Goyle study is, let's see if we can get some daytime napping in. So that may mean bringing somebody in to kind of handle like the house into, so she can, even if she doesn't sleep, if she can just go relax, sit and read a book, or just kind of like watch something on Netflix. She can just do something that she really can kind of, I think you're going to find that's really going to help a lot. So this is, when you got somebody who's hanging on by a thread, what you need to do is start mobilizing the social support. So it could be just sitting down and kind of planning, how would we do this? Now, in terms of sleep medications, yes, there's lots of things that you could take that help with sleep. One of the things that helps with sleep is antidepressants sometimes. This is like, if you can deal with the depression, a lot of times sleep gets better. You can say that, things like some of the apps, there's, some nice apps, that talk about sort of calm and meditation and, that kind of stuff. That actually helps. But I would say if she's on medication, here is the really key bit. She cannot be sleeping with her baby ever, because anything that she takes that it impairs her responsiveness, if she can't have the baby next to her. She can have the baby in a separate space, but the baby cannot be next to her. So the baby needs to either be in like a co-sleeper or one of those little baby boxes, or, in a bassinet or pack and play. Some families have even used like, say a drawer. There's really actually honestly nothing wrong with that, as long as there's no place for the baby to like roll into and get caught, in an edge. That there's lots and lots of assortments that are kind of available for all income levels, but it is really critical that she, not sleep next to that baby. What they did down in New Zealand, and they actually did this because the Maori tribe, actually their SIDS rates were really high, even though they were all breastfeeding. And it was because they smoke too, real high rate of smoking. And so what they actually encouraged is they used these, they wove these traditional baskets, kind of like Moses baskets. And then they had the babies sleeping in there. So the baby was still near, but was not right next to, and not bed sharing. And it cuts the SIDS rate way down. I think it cut it in half, So again, like I said, that is one critical thing. And, because I think sometimes we do a little don't ask, don't tell with sleep, honestly, especially in the US, because we're, a lot of places are just not allowed to talk about it. But this one is really, let's make sure we get this message through very clearly. It's like, okay, if you're going to do this, this is what you have to do to keep your baby safe.
Awesome. Yeah, so I have a few more. It says some are just thanks and compliments. Kathy,
Okay.
you're a jewel. I always learn so much from you. Thank you. One here says mothers are not attending prenatal classes in our area, especially those most at risk, socially
Yeah.
vulnerable, etc. History of anxiety and depression. Do you have any brilliant ideas or programs working in your area? Thank you for all the work you do. I've followed you for years as a lactation consultant in Saskatoon, Canada.
Well, thank you very much. That's very nice to hear. But I'm wondering, did you come when I was up there a few years ago with Lola Lake? Because that's actually, I was up in Saskatoon. But I think actually it is very difficult. the prenatal education bit is really hard. You know, it's hard kind of across the board. I know a lot of childbirth educators, and they just said that, you know, the rates have just plummeted because people think that they can get the information online. So I would say probably the thing that has to be done is, I think you're not going to probably get this particular population to formal classes. And so, you know, whatever other programs you're using, I would probably try to integrate bits of like education into those other programs. You know, so if you're, you know, involved with a supplemental feeding program, you know, that maybe there's like a little 5-minute, you know, or 10-minute little blurb talking about some of the things you want to talk about in a prenatal education class. If you're seeing them in the context of, you know, prenatal care, that would be maybe a time, you know, maybe somebody could sit down in an office, you know, and talk. It's probably not going to be the primary provider, just because, I mean, there's a lot of times limits in terms of time, but maybe that's when you bring in somebody to kind of just, you know, have a chat and kind of find out, what are your questions, and, you know, what are you worried about, and kind of like find out kind of what are their concerns and questions. Now, the other thing that's been actually really kind of interesting is they run a program called Best Beginnings in the UK, and they've developed this app. It's called the Baby Buddy, and it's really, is it Baby Buddy or Bump Buddy? But it's really a nice program. So look up Best Beginnings if you want to like see about what this is. But what they were trying to do was address the, you know, high rate of infant mortality, particularly among the low income white population. They were just really kind of having a problem with this. And so they developed this app, and you get like little points, you know, for doing things. And it, you know, it's very interactive. And so you can make an avatar. So like if you do something like, say, you go to 2 prenatal appointments at all, you get some earrings for your avatar. I mean, you would think that this kind of stuff wouldn't be motivating, but it actually is extremely motivating. But they have little video clips on there. They have, you know, things that where you can, you know, access smoking cessation programs, just all kinds of resources that they've woven into something like that. So something like that actually could also be, because, you know, even sometimes, you know, except for the probably the most impoverished families, you know, oftentimes this generation, you know, they have cell phones. And so, you know, that could be kind of another way to kind of reach, you know, or like, you know, I know there've been some great breastfeeding support programs that have used texting, you know, so they enroll people and then they sort of text them sort of relevant things, you know, like at maybe different stages of their pregnancy, they might text them a little message or something. So again, like I said, I think just trying to kind of, you know, try to integrate it, I guess, into other care, and kind of also kind of like figure little bits. Let's work in little bits here and there. And, you know, I think by the time you do that, you'll have a whole class. But I think actually, again, like I said, thinking about kind of breaking it down, because I agree. I think that they're not going to darken the door. And it's kind of like they're not going to darken the door of a depression support group. And so again, can we weave mental health care into some of these other things that we're already doing? I think that's really kind of the way to go in terms of really reaching these families.
Thank you, Kathy. And I'll just mention that we also have a prenatal app here in Saskatchewan that
Brilliant.
can be a bit of benefit, My Saskatchewan Pregnancy. So yeah,
Mm,
so that's also something we've incorporated a
excellent.
little maternal mental health resources in. So
Now, is that something that other people outside of Saskatchewan can access to?
it's actually a Saskatchewan-based app. So it was created for the population living in Saskatchewan. So mainly for Saskatchewan.
Okay.
Yeah.
I was just thinking, you know, I know we have a lot of people from different places, but yeah, so I mean, that actually, you know, that could be something too. Maybe you drop Temmie note and found out how they did that and kind of what kind of resources they needed to get that app put together. But yeah, I think actually, as I said, that's been quite successful in the UK. I know that.
Yeah. Okay, I have a few more, one or two. Kathy, so good to see you and hear your wisdom backed up by so much research. We still hear all these myths. I am in my area, breastfeeding support took a dive during the pandemic. Always
Mm.
love hearing you present.
Thank you. Who is
Yeah,
that?
that is Swati Scott. Yeah.
Swati. Hi, Swati.
Okay.
Actually, here, I've got your business card holder right here on my desk. Let me look for
Oh,
it.
nice.
Swati was the most excellent hostess.
I think that kind of ties into the question I had, that seeing that breastfeeding rates are kind of dropping. So what's kind of the way forward, since breastfeeding is kind of a protective factor in this whole piece, and the breastfeeding rates are dropping? How can we move forward, or what kind of approach can we help to support women in this situation?
I think honestly, probably the next place that we have to go, and particularly with some of our higher risk populations, is I think if we can coordinate with the mental health providers, because I think honestly, sometimes we're working against each other, because their best practice is that you get the mom to stop breastfeeding, and it's like you're kind of working kind of at cross purposes. Theirs is, like if breastfeeding is too much, you just sacrifice it, and it's like, I mean, I'm a psychologist. And so it's kind of like when I talk to some of my fellow psychologists about this, and I tell them, look, this is what's going on here. And they're always surprised. And so I think if we could reach out to the mental health providers, I think that would be one step, because I think they're going to be getting some message. But I think also too, something that has really gotten lost is there's kind of been a de-emphasis on exclusive breastfeeding. And I understand why, because, the idea is we don't want to make it too hard, and it's like, it always just kills me when I hear these stories, and you find out that, these women have struggled, for weeks and weeks and weeks, and they've been, miserable and cracked nipples, and they've been bleeding. I mean, it's just, and, or their milk supply is just chronically low, and they're on these horrible pumping regimens and stuff like that. I mean, it's just awful. And what that really honestly speaks to is, I think, not good breastfeeding support. I think sometimes people that are, quote, supporting breastfeeding don't necessarily have the technical skills that they need, so they'll tell families, oh, just keep doing what you're doing, and it's like, that's an awful thing to hear when you're really struggling that much. And so it's kind of like, I think part of it is, let's kind of have a bridge between lactation and mental health, because I think that's going to be kind of a critical part. But also, how can we ensure that there is like higher rates of exclusive breastfeeding? And I think, because that's where we're kind of missing a lot, we're getting a lot of melt off. And I think probably the group that's probably most at risk for, depression and PTSD and anxiety and stuff during that postnatal period is actually that group that tries. They start off and then they drop off within a couple of weeks, or 4 weeks or 6 weeks, and that we lose them. And I think that they're, because that by itself is another risk factor for all of these things, so I think part of it is identifying and recognizing that some of these mental health things are really direct threats to breastfeeding, and coordinating with our colleagues in mental health care, but also making sure that there's enough support that this is going to work. And I think that that's been a technical difficulty. And also too, during COVID, this has been wickedly hard, isn't it? But some interesting things have come out of COVID, actually, that I think can make us think, that there might be different ways we can do this. I mean, like one of the things is, some lactation consultants have reported that breastfeeding support actually got better via Zoom. One of the reasons is because a lot of times it was the partner and the mother participating together. It's like the partner would have to hold the phone in a certain way so you could see it, or they would be listening, and they would be working together, and there was no lactation consultant to sit there and stick their hands in. Which I think a lot of times, honestly, we're tempted to do, and I know I am, I'll speak for myself. And so I think actually there've been some positive things that have come out of this. I think that, the difficulty and the challenge is, I think there were just an awful lot of very, very, very isolated families during this. It's like, I live on the border of New Mexico, and it's like, I mean, the level of isolation there was really, really hard, because a lot of people, and I know we have several people from New Mexico on, you can actually, I know this, but there were so many people who were really isolated. And I know probably, I can think of some areas probably in Saskatchewan, same kind of thing, where internet access is kind of limited, and there wasn't a real easy way to kind of reach out. And I think that's actually really had a big impact, but I think, the approach that we need to take now is kind of think about kind of how can we move forward. But I think actually, supporting the exclusive and recognizing that it is a separate thing, and then coordinating, I think with mental health care is probably the two things, that we can do that can kind of boost our rates with this particular population, but recognizing that there's going to be a lot of other support. One of the things I kind of recommend when I talk about things like substance use, is a lot of times, not surprisingly, there's a huge trauma history in a population that is using substances, during pregnancy and breastfeeding. We're looking at some data now, looking at cannabis use. And I mean, when they looked at adverse childhood experiences in the original study, so that big sample that was out in San Diego, California, and I know I had somebody from San Diego on here, but when they looked at that, they found about 50% reported at least one type of adverse childhood experience. Okay. In a cannabis sample, it was 89%. And so some of the women in that sample had experienced unbelievable amounts of violence in their lives. So in some ways it's not surprising that they were using substances because it was the only way they could sort of cope with their day. But one of the things that actually some really effective programs have recommending is that, we start coordinating, our breastfeeding care with a lot of other services, and again, like I said, a lot of times it doesn't necessarily need to be that you form a whole other organization to do this. But, if we can find a way to like start connecting with what are the other resources, what are the resources for partner violence, what are the resources in the town for housing assistance, and just knowing that in the community, I think that can be a first step in kind of moving toward that more coordinated care, where, okay, you know what, this is really difficult right now because, she is actually really having trouble with depression. Okay, so how can we get some care for depression in here, and how can we work together to ensure, the mental health and the mental health support for that mom? So coordinating with other resources within a community, I think, can be helpful. I think probably the next step beyond that is probably maybe having a monthly meeting. Bring in the stakeholders and actually like work together. And actually specifically say, okay, listen, I have a family in this situation, and then can we send them your way? That could be like an ideal to work toward. But the first step is just knowing kind of what are the resources, because recognizing, again, like I said, a lot of this is not within scope of practice of lactation consultants, but I think we do need to recognize that these are viable threats to breastfeeding, and we want to make sure that there's support there for those families, that want to continue but are struggling with some different things.
Thank you. I think we're kind of out of time now. Just sneak in this last one. It says, "Is the Best Beginnings Baby Buddy app available in Canada?" I don't think so. Is it?
I'm not sure. It
Yeah.
sounded like what Allison was saying is that you could actually download it, but so I'm not 100% sure about that.
Okay.
But let me look up Allison's.
I think it's just way of checking is just check on Apple on Play Store and
Yeah.
to see and try and download it if it works or not.
I
Yeah.
would say, and it could be worth like just shooting them an email, because, oh, you know what? I know that they have actually just released a version of that in Greece.
Okay.
So I bet they would be willing to possibly share. Now, obviously it would probably have to be adapted, but I wouldn't be surprised if there was a way to kind of coordinate with each other. It really is a fantastic thing. But even if it's just used as, an idea, for what could we do? It sounds like you've already got an app that sounds really terrific. And it's like I said, kind of adding on that, but thinking about kind of how can we reach this generation of mothers? It's kind of like we have to kind of go in some ways where they live, which is, oftentimes on their phone.
Yeah. Okay. I
For
think
better or worse.
I think Tonya just says, love the idea of stakeholder meetings, and some comments about the vicious cycle of the anxiety, depression, pumping, and all that.
Oh yeah. Yeah,
Yeah.
that can be so bad. I was actually reading a book. It was a little self-published book, and she was talking about this regimen she was on. And I thought, that can't be good. I'm not sure that the milk is necessarily worth this miserable experience, honestly. There may be other alternatives to think about that actually might be a little bit better. It just sounded absolutely horrible. This person was actually pumping after having a breast reduction, so, but she was on lots of different, galactagogues, and she was doing, and it was just, I mean, at a certain point, you got to be thinking about not only her mental health, but also the relationship with the baby, because it's like, to me, this is the big goal. What we really want is we want to, no matter what, we want to make sure that there's a secure attachment formed, and I think honestly, as a parenting goal, as much as I love breastfeeding, and I do, because I've been talking about it for the last hour and a half, but I think the bigger parenting goal is that there's a secure attachment formed, and I think that supersedes it. And so it's like, for families, when breastfeeding doesn't work out, there's a lot of other ways to get there. I think the encouraging thing to know when you get these families that it didn't work for whatever reason, it could be that there was, really bad advice, that could be that we lost out on that first couple of weeks in terms of frequent breast. I mean, there could be anything, there could be some biological issue. The thing to know, though, is it's the responsive care that causes that. And most of the original research on attachment was actually done with formula feeding infants. Okay, so you can get there without that. Breastfeeding, I think, facilitates it, because it raises oxytocin and it does all that. And you have to have responsive care in order to breastfeed successfully. However, if that doesn't work, let's think about what are some other ways to get there. We could do it with infant massage, we can do it with baby carrying, we can do it with, like using a supplemental nurture. I mean, there's just all kinds of other things. Paced bottle feeding, these are all things that will actually promote that secure attachment. So again, we kind of have to have that in the back of our mind. Not that we toss away breastfeeding, but I think sometimes, when you look at something like that really punishing regimen, I think to myself, it didn't seem like a good idea. She seemed miserable. I mean, the whole point of the book was to complain about this. And I think actually, apparently, I think she's got a whole website where they all, sit there and have conversations about these miserable, and I think at some point, there needs to be a kind of a discussion about, okay, cost and benefit here.
Yeah, thank you so much. It's been an interesting conversation. Unfortunately, we won't be able to take more questions because we're way out of time. Yeah,
It's okay.
Yeah, I wish we could go on and on and on, but hopefully we'll have you again for another webinar. Thank you, everyone, for attending today's webinar. Thank you, Dr. Kendall Tackett, for that awesome presentation and engagement so far. After this webinar, you would see a link to a survey, feedback evaluation. Please kindly complete it. I would also be sending out the handouts that Dr. Kendall Tackett promised, as well as a link to the recording once it's available on our website. So for those who want to rewatch or want to share with other people, that will be of use to you. Once again, thank you so much for joining in today's conversation. Do have a great, enjoy the rest of your day, whatever you get up to.
Thank you very much.
Yeah.
And I think I'm going to see you guys again in November.
Yeah, we're going to have one on violence prevention in the perinatal period. So watch out for that.
Okay, well, thank you very much, Timmy. I will see you next month. And thank you everyone for attending today. I will actually, as soon as I get off this, I will send over the handouts and then we can share them with everybody.
Sure, I'll do that.